Hello, everyone. It's a pleasure to be here today. I'm honored to speak on global collaboration in consensus building, a critical component for advancing research and improving patient care. We will begin by looking at what is consensus building, why it's needed, and how it supports clinical decision-making, especially when high-quality evidence is limited. Then we will explore why global collaboration is essential for ensuring that outcomes are inclusive and applicable across diverse patient population. I will walk you through key methods used in consensus work, focusing on the Delphi method. We will then use the IPC consensus definition and diagnostic criteria for GPP as a case study to illustrate real-world challenges before concluding with a few key takeaways. Here are my disclosure. So what is consensus building in medicine? It is a structured process for reaching agreement on a specific issue among experts or stakeholders, especially when evidence is limited, conflicting, or still developing. It is an intentional, thoughtful effort to find common ground across differences in culture, language, scientific training, and healthcare system. It involves active listening, challenging ideas respectfully, and working towards decisions that most, if not all, can support. The goal isn't necessarily unanimous agreement. It's about developing a balanced, informed recommendation that reflects available evidence and the collective judgment of the group of experts. Consensus statement or guideline often become the foundation for best clinical practices and support decision when the clear evidence is lacking. Consensus building is essential when high-quality randomized control trials aren't available to guide treatment decision. And this is especially true for rare diseases, which are often difficult to diagnose and poorly understood due to limited data. Consensus building is also crucial when there is wide variation in how we assess disease severity and treatment response. Without standardized measures and approaches, it is difficult to compare studies or establish best practices. Consensus building aligns expert opinion with available evidence, supporting standardized approaches to diagnosis, treatment, and evaluation of response. This will lead to a more consistent and reliable care and make it easier to compare findings across study and clinical trials. So why does global collaboration matter in medical consensus? Bringing together experts from diverse regions, specialty, and cultural background lead to more balanced and higher quality recommendation. It helps minimize bias by incorporating a wider spectrum of clinical perspective and lived experiences. This diversity is especially important for addressing region-specific challenges like limited access to care or differences in disease prevalence that might otherwise be overlooked. Global input also promotes equity in how we diagnose, treat, and manage diseases, ensuring that guidelines are culturally sensitive and applicable across different healthcare environments. And when stakeholders from around the world are involved in the consensus process, it builds trust and increases the likelihood that the resulting recommendation will be adopted and implemented more widely. So in short, global collaboration is key to building medical consensus that is credible, relevant, and equitable across different populations and healthcare systems. Now that we understand why global collaboration matters, let's look at how consensus is actually built. Consensus building combines scientific evidence with collective expert opinion to define diseases, set standards, guide clinical practice, and identify the best approaches to care. And key methods used to build consensus include the nominal group technique, the Delphi method, and the RAND-UCLA appropriateness method. In the nominal group technique, experts first generate ideas individually. Then they come together in a face-to-face meeting to discuss and rank those ideas as a group. For example, the European Rare and Severe Psoriasis Network, or ERASPN, used a modified version of the nominal group technique to define different phenotypes of pustular psoriasis. 5 dermatologists and a geneticist met in person and unanimously agreed on diagnostic criteria for GPP, ACH, and palmoplantar pustulosis. This criteria was then shared with the wider ERASPN network for feedback, and the final version was confirmed with full consensus from the core group. The Delphi method, which we will explore in detail shortly, uses multiple rounds of anonymous survey and feedback to refine expert opinion and build agreement over time. Finally, the RAND-UCLA appropriateness method blends a thorough literature review with expert rating to assess whether certain surgical or imaging procedures are appropriate for specific clinical scenario. The Delphi method brings together a panel of experts to reach consensus on complex or uncertain issues, and this is done through multiple rounds of structured questionnaire where responses are collected anonymously, summarized, and then shared with the group before the next round, eliminating the need for face-to-face meeting. Experts then adjust their opinion as they consider new ideas shared in each round without the influence of group dynamics or dominant voices. Over successful round, typically 2 to 4 opinions begin to converge, ultimately leading to a more informed and balanced consensus. The modified Delphi method builds on the traditional approach by adding real-time interaction, and it often involves face-to-face or virtual meeting guided by a facilitator who keep the discussion focused and respectful. This interactive format improves communication and engagement among experts and create a more dynamic yet controlled environment ideal for making well-informed collaborative decisions. The Delphi methods begin with a core group clearly defining the problem or issue that needs expert input. This group is also responsible for developing the initial set of questionnaires aimed at guiding the expert panel towards consensus. And the carefully selected panel experts then respond to this question over multiple rounds. After each round, responses were analyzed, summarized, and the feedback is shared to inform the next round. This iterative process continues until a consensus is reached. Unlike the RAND-UCLA method, which required a literature review to guide question development, the Delphi method does not necessarily require a literature review as its foundation. Instead, it relies more heavily on expert opinion and group judgment to shape the discussion and final outcome. So while the Delphi method doesn't always require a literature review to create questions, in medical consensus processes, especially when developing treatment guidelines, a review of existing evidence is usually an important first step. However, there are situations where a literature review may not be practical or optimal. For example, when developing the international definition and diagnostic criteria for GPP, we relied on the evaluating complex real-world cases submitted to us online rather than a formal systematic review of literature. And this was necessary because published data on GPP was limited. So now let's use the IPC consensus or GPP as a case study to highlight some of the key challenges faced when using Delphi method to build consensus. The first challenge is choosing the right expert. We need people with strong, relevant knowledge who can stay objective And if the panel is unbalanced with too much influence from one region or specialty, the results may be biased and less trustworthy. Similarly, if the panel is too homogeneous, for example, if they come from a single region, discipline, or clinical setting, we may miss important viewpoint. And this is a significant risk in global health, where diseases, access to care, and treatment can be very different from one place to another. To address this, set clear selection criteria, looking for relevant expertise, clinical experience, and a strong understanding of the topic. Also aim for diversity, not just in geography, but also in clinical versus academic background and different healthcare setting. This helps ensure the panel brings well-rounded and globally relevant perspective. The second challenge is panel size and composition. If too large, managing input and synthesizing feedback become difficult. And if it's too small, we risk missing important viewpoint. If an expert group of usually 10 to 30, it depends on the complexity of the topic and issue, is adequate to get sufficient information. But if we are dealing with more complex issue requiring larger panel size, consider dividing the panel into subgroup to tackle different components of the topic, and their finding can be integrated during later Delphi rounds. The strength of any consensus process lies in the quality, diversity, and experience of its expert panel. For the IPC GPP consensus, we intentionally assemble a panel of experts representing all 5 continents. And this global representation ensures a broad spectrum of clinical research and regional perspective. Our panel comprised 33 experts from 24 countries. Most had over 2 decades of experience and had treated on average 20 GBP patients in the past 5 years. And this is a significant number given the rarity of a GPP. This level of diversity and depth of expertise was essential for developing diagnostic criteria that are both clinically meaningful and globally applicable. And equally important, we documented the panel selection process in detail. Transparent reporting of how experts were chosen enhances the credibility of the consensus, and reviewer of consensus publication and readers rightly scrutinize the panel's composition to assess its rigor, inclusivity, and relevance. So do remember to include patients, especially in consensus on outcome measure and management. And according to ICHOM, the International Consortium for Health Outcome Measurement, patient participation is mandatory, and patients should make up at least 25% of the working group. The historic consensus on core outcome for hidradenitis suppurativa is a strong example of inclusive and diverse global collaboration. This process brought together 41 experts from 13 countries across 4 continents, including patient dermatologists, dermatology surgeons, pharmaceutical industry representative, and medical regulators. And participants were divided into subgroups to address specific topics. History was one of the few consensus efforts conducted in person, which gave me the invaluable opportunity to engage directly with a diverse group of experts and patients. And it was a memorable and enriching experience that deeply enhanced the collaborative process. That said, in-person consensus meetings are often difficult to organize and they are very resource intensive. Today, virtual meetings have become the standard, offering broader accessibility while still maintaining meaningful engagement. Once an excellent panel is selected, it is crucial to keep them engaged throughout the process. Experts can experience fatigue or decline in interest after multiple Delphi rounds, which may lead to reduced participation and engagement. And this will ultimately skew the results and compromise the reliability of the consensus. To address this, is essential to clearly communicate the time commitment to the panelists upfront and ensure that they are committed to participating in every round. Limit the number of rounds. Striking the right balance between thoroughness and efficiency is key. Aim for 2 to 4 rounds, which provide enough feedback while avoiding participant engagement and fatigue. So keep the rounds concise, ensuring questions are focused and straightforward to maintain their engagement. Ideally, questions should be limited to 25 words, and this is to prevent cognitive overload. While free text responses can provide valuable insight, they should be used carefully due to challenges in analyzing free text responses, and avoid overwhelming participants with too many questions. Consider offering incentive or recognition for participation to maintain engagement and also to demonstrate your appreciation. Another key challenge in Delphi method is achieving true consensus. While the process encourages convergence of opinion over multiple rounds, experts often bring in deeply entrenched views shaped by their own clinical practice, cultural context, or academic background. As a result, agreement can be difficult, and even after several rounds, some items may remain unresolved. And when consensus is not achieved, how to handle all this agreement may also be unclear. Therefore, it's essential to define what constitutes consensus upfront and establish rules on handling disagreement and facilitate constructive discussion to clarify misunderstanding and find common ground. A 70 to 80% agreement threshold is usually widely accepted benchmark for defining consensus, particularly in medical and health-related consensus processes. It offers a practical balance, ensuring that decisions aren't made by a slim majority and preventing a small minority from blocking the progress of this consensus. This range works well for typical Delphi consensus of 10 to 30 experts, and its use is well supported by research on consensus methods. The key is to define this threshold upfront and apply it consistently to keep the process clear and trustworthy. Consensus is often defined as 70 to 80% agreement among panelists on a given item. Many studies enhance this approach with a 9-point Likert scale, where scale of 7 to 9 indicate agreement, and if 80% of panelists rate an item in that range, is considered to have reached consensus. The benefit of using a Likert scale over a simple yes or no vote is that it captures how strongly experts agree, not just whether they agree, and that difference can be important. For example, if 15 out of 16 panelists score an item between 7 and 9, it meets the 80% threshold. But if most of those scores are 7, the agreement may be weak, suggesting the need for further discussion and refinement. Now compare that to another item where only 13 out of 16 gave a 7 to 9 rating, but 12 of them scored it a 9. Technically, the consensus rate is lower, but the strength of agreement is much higher, indicating stronger confidence in the recommendation. The Likert scale also helps us see how opinion change over time. If the score improves across round, it shows growing agreement. If they stay the same, it may signal that the group is stuck and need more discussion and refinement of the item. So Likert scale also allows us to know more detailed analysis like finding the average score or how much opinion differ. So while a 80% rule is simple and clear, the Likert scale gives us a deeper and more useful picture of expert opinion. This table compares using an 80% agreement threshold versus a Likert scale. With the 80% threshold, responses are binary, typically agree, disagree, yes or no. It's best suited for clear-cut decisions such as defining diagnostic criteria or inclusion and exclusion rules. The results are easy to interpret and act upon with low subjectivity, making it ideal for rare disease work where clinical clarity is critical. In contrast, Likert scale offer more detailed feedback, allowing panelists to express how strongly they agree or disagree. And this is particularly useful when ranking priority, exploring emerging concepts, or refining complex recommendations, such as treatment goal in chronic inflammatory skin diseases, where expert opinion may vary in strength. However, interpreting Likert's result often require additional analysis such as calculating median or interquartile range, and the subjectivity of scale interpretation can introduce ambiguity. So while 80% agreement is limited in detecting subtlety, it delivers clear and actionable outcome. On the other hand, Likert scale helps capture subtle variation in expert opinion. So in short, use binary threshold when you need clear, decisive answer, and the Likert scale when you are dealing with complexity or prioritizing, or when you're prioritizing something to capture varying level of agreement. Now returning to the case study, in the IPC GPP consensus process, we tailor our method for statement development and consensus building to address the unique challenges of a rare disease. Due to the rarity of GPP, available literature is limited and often lacks the detailed clinical information needed for practical diagnostic guidance. To overcome this, we took a pragmatic approach. We invited experts to contribute real-world GPP cases from their own clinical practice, and this resulted in a diverse data set of GPP cases which captured the clinical variation across region and population and informed the development of Delphi statement grounded in real-life experience, not just theory or incomplete data. And this approach helped the panel focus on the actual diagnostic challenges faced by clinicians. Notably, 78% of cases involve patients with darker skin tones, allowing us to explore how GPP present across different racial and ethnic backgrounds. And by anchoring our process in lived experiences and the population diversity, we created diagnostic criteria that are inclusive, practical, and globally relevant, supporting earlier and more accurate diagnosis for all patients with a GPP. We developed 43 statements covering clinical, histological, and laboratory features essential for diagnosing GPP. All but one were kept under 25 words to minimize cognitive overload. And consensus was defined upfront as a straight 80% agreement, clear, binary, and intentionally chosen over Likert scale. While Likert's responses offer gradation, they often introduce ambiguity. In contrast, the binary approach provided clarity, reduced subjectivity, and supported transparent decision-making. And the 80% threshold ensured each statement have a strong support without requiring full unanimity and appropriate balance for developing diagnostic criteria. Statements were refined and voted by a panel of 33 global experts across 2 virtual consensus meetings, shaping the definition and diagnostic criteria for GPP. I'm sure most of you are familiar with the IPC definition and diagnostic criteria for GPP. GPP is a systemic inflammatory disease marked by visible scleral pustule on red inflamed skin. It can occur with or without systemic symptoms like fever or fatigue and may or may not be associated with other forms of psoriasis. GPP may present acutely with widespread pustular eruption or in a more subacute form, often with an annular phenotype. Laboratory abnormality may or may not be present. And the key diagnostic criterion is the presence of microscopically visible serum pustule on an erythematous base, not limited to acral region or within existing psoriatic plaque. And supporting features include characteristic signs like leaks of pus, painful skin, fatigue, fever, and laboratory abnormality. Histopathology consistent with GPP and the presence of known genetic risk allele can also support the diagnosis. A history of recurring flare or a personal or family history of psoriasis may further strengthen the clinical suspicion. The IPC consensus on defining and diagnosing GPP, a rare and complex disease, highlights the importance of a global collaboration, innovative approaches, and expert insight in effective consensus building. And before I close, I want to sincerely thank my colleagues listed here. Some of you may be in the audience for their invaluable contribution to this work. And to wrap up, here are the key takeaways. Consensus guide practice when evidence is limited, and involving a global community in consensus processes bring essential diversity across geography, expertise, and patient population, making the outcome more inclusive and applicable worldwide. Structured approaches like the Delphi method ensure rigor and clarity, and collaboration across country, time zones, and professional culture require effort and coordination. But it is worthwhile, as we saw in the IPC GPP case study. Global collaboration combined with a strong process can lead to practical output, such as the diagnostic criteria for GPP that are both clinically relevant and globally inclusive. And with that, thank you for your attention.